Today we'll be dealing with Candidiasis. This is another important topic where and so also in your Bible. So to vaginal candidiasis. Candidiasis is a domestic pathogen. Candidiasis albicans grow in several different morphological forms. Unicellular budding yeast to true hyphae with parallel sidewall. Is a unicellular oval-shaped diploid fungus, a form of yeast. Typically, Candida albicans as harmless intestinal urinary and are genital and are population. Overgrowth of these organisms lead to this incidence type of Candida where Candida glabrata, Candida albicans. So you must have noticed that are the most common and it accounts for 80 to 90% of the patient. Candida glabrata is the second most common and it accounts for 50% of the comes Candida tropicalis. Other species, Obgy, Candida Guillermendi, but they are rarely seen. In recent years, particularly Candida glabrata, Candida tropicalis, and especially it is present in Candida account for 20% of the cases and 30% of recurrent cases. Widespread and inappropriate use of antimycotic drugs and short may lead to an overgrowth of Candida. Causes a selection of species such as Candida glabrata that are resistant to commonly used drugs. Eradication of intestinal Candida with medication is not successful. States. One is blastospore or spores and second is mycelia. Blastospores are phenotype for extension, dissemination and mycelia are germinative form and this phenotype can invade tissues and cause. This is how it looks in. If you see the epidemiology, about 75% of the women suffer from infection in their lifetime, once at least, and in 40 to 50% of them additional. Now, what are the predisposing factors? Why do you get Candida vulvovaginitis? There are different factors. One, immunity, other vaginal infections, trauma maybe because of the sexual intercourse, causing skin sensitization, late pregnancy and immunosuppression. All these are compromised immunity states like diabetes mellitus, thyroid disorder, parathyroid disorder or adrenal. Menstrual in late or drugs which are responsible for antibiotics, anti-trichomonal, clothing, and tight clothing. Now coming to pregnancy state, you have high estrogen levels which cause an increased glycogen load in epithelium, which is a nutrient promotes fungi are more capable to penetrate vagina. OC pill containing high estrogen, the mechanism is same as in pregnancy. Diabetes mellitus, metabolic disturbance predisposed to clinical vagina. Antibiotics suppress lactobacilli flora and the candida are free to grow, adhere, germinate. However, several studies fail to show this. Now coming to virulence factors. Candida several factors which make it harmful to its host. One of which is its use of cell wall adhesins. The adhesins proteins promote the binding of organism to host cells. Interaction. This the level of yeast clearance from body under normal immune regulation. When Candida albicans penetrates host mucosal surface following morphogenesis into the polymorph yeast host tissue by enzyme, various proteases, aspartyl proteases and phospholipases. Phenotypic switching also plays a role in altering the yeast adherence properties and switching cells with flexibility that results in adaptation of the organism to the hostile conditions by the physician treating infection. Coming to pathogenesis, Candidiasis is caused by abnormal overgrowth in Candida albicans, due to imbalance in women. Several events can spark an imbalance. For example, the antibiotic use can decrease. Candida albicans are able to take advantage of the conditions and outcome normal candidiasis or a yeast infection. To be invasive, Candida follows three-stage mechanism. Second is blastospore germination, mycelium or hyphae development, epithelium invasion. But you have defense factors against Candida in vagina normally, which are lactobacilli, humoral immunity, that is antibodies, and cellular immunity. The transformation of vaginal colonization into vaginitis is a critical step in pathogenic mechanism of Candida vaginitis. During colonization stage, Candida albicans are present basically in the blastospore form and their number is not very high. There is a balance between Candida organism and vaginal defense factor limiting an increased number of enhanced virulence of Candida or a decreased vaginal defense mechanism. When this occurs, blastospore adhere to the vaginal epithelium and germinate. Mycelium develops and finally invades the mucous membrane producing vagina. Vaginal is usually transferred from mother to infant through the childbirth as a part of normal human microflora. Candida albicans very rarely spread through sexual intercourse, but it has got a chance of spreading. The typical reservoir for Candida albicans is in normal human, not found. Source: vagina, GIT, and from the husband. Vagina, 35% of the healthy females. Secondary opportunistic anorectal transfer. Husband, 25% of STD. Vulvovaginal candidiasis is not usually acquired through sexual intercourse, but there is a chance. Coming to symptoms, vulval itching, a cardinal symptom, which is intense itching, so it's the main symptom, increases with warm and at night. Vaginal discharge, it is not predominant symptom. It may be scanty, a thick curdy white adherent to the vagina, to thin watery discharge, and pH is 4 to 5. Burning, vulval and vaginal is not dominant but gets worse with maturation or coitus. There may be dyspareunia because of external dysuria, again because on examination you will find thick curdy white vaginal discharge, that is cottage cheese like appearance, erythema, irritation, occasional erythematous may be seen. Diagnosis is by taking history, signs and symptoms, visualization of pseudohyphae, that is mycelia and or budding yeast on 10% KOH or saline wet preparation. pH, it's normal is 4 to 4.5. pH 4.5 trichomoniasis infection. Cultures are not usually done routinely for the diagnosis, but if it is required, then Nickerson or Savarez only when microscopy is not diagnostic. Diagnosis of a yeast infection is a microscopic examination or culture. For identification by light microscopy, a scraping or a swab of affected area is placed on microscope slide. A single drop of 10% potassium hydroxide KOH is then added to the specimen. Cause the skin cells but leaves visualization of pseudohyphae and budding yeast cells typical of many. For culture method, a sterile swab is rubbed on the infected skin surface. The swab is then streaked on the culture at 37 degrees centigrade for several days to allow development of yeast, bacterial morphology and color of the colonies, may allow initial diagnosis of the organism causing disease or the. This is how the curdy white discharge looks like and the inflamed vagina and vulva. This is the picture on microscopy. Coming to differential diagnosis, causes of vaginal discharge, maybe because of the infection or vulval disease infection, maybe with herpes genitalium, vaginosis, vulval disease, especially vulval eczema, dermatitis, like vulval. Ask the patient to identify if there are symptoms of dyspareunia. The Q-tip test for the vulval vestibulitis syndrome should. Coming to classification of Vulvovaginal Candidiasis, it is grouped in two broad groups. One is uncomplicated VV and second is complicated Vulvovaginal Candidiasis. Uncomplicated VVC is again subclassified as or infrequent Vulvovaginal Candidiasis. Second, mild to moderate Vulvovaginal Candidiasis. Third, likely to be Candida albicans. And lastly, Vulvovaginal Candidiasis. Complicated Vulvovaginal Candidiasis, you have severe Vulvovaginal Candidiasis, non-albicans Candidiasis, and lastly Vulvovaginal Candidiasis in women with uncontrolled immunosuppression. Coming to uncomplicated candidiasis, there are mild to moderate signs and symptoms. It is usually non-recurrent. 75% of the women have at least one episode in their lifetime, and it responds to short courses of treatment. Treatment asymptomatic should, even if culture is positive. It's only for symptomatic women. In uncomplicated, local tropical intravaginal antifungal, that is either nystatin or azoles like clotrimazole, miconazole, diaconazole, turconazole, all these azoles can be used. Both the azoles and nystatin are fungistatic rather than fungicidal. Nystatin is less effective treatment given for 14 days, but is indicated if there is possibility of non-albicans yeast infection. Azoles resulted in higher rate of clinical and mycologic cure to 95 statin and in non-pregnant acute VVC. Short courses, single dose and regimens of 1 to 3 days VVC should be treated, where ketoconazole 200 mg days or I mg for 150 mg 1 tablet single dose. No difference in effectiveness for the uncomplicated candidiasis in oral or vaginal antifungal agents. The oral route is preferred route by the patient. The oral or based on cost, effectiveness and patient's preference. The oral preparation is more expensive and associated with more systemic route line of therapy. Patient should be instructed to return for follow-up only if symptoms persist or recur. Now, what are the causes of clinical failure? Diagnose chemical, perfume products, detergents, physical damage, maybe because of sexual intercourse or tampons, and the causes of therapeutic failure, in spite of diagnosis being correct, resistance agents, It may be because of infection of species outside fungal agent. Non-albicans candidiasis are associated with vaginitis and are more resistant to conventional antifungal therapy. Candida glabrata and Candida krusei are resistant to the fluconazole and itraconazole. Coming to treatment, vaginal culture should be obtained to confirm clinical diagnosis and to identify unusual species. Usually it is done on blood agar, including non-albicans species, particularly Candida. And the treatment given is longer duration of initial therapy, 7 to 14 days of topical therapy, or 150 mg of oral dose of fluconazole repeated every 3 days, that is achieve ecological remission before initiating a maintenance dose. In contrast to severe vulvovaginal candidiasis, of therapy by adding a fluconazole. The maintenance or suppression therapy for 6 months is given after initial therapy, where you can use clotrimazole 500 mg dose vaginal suppository once a week, ketoconazole 100 mg once daily, or fluconazole 150 or itraconazole 400 mg once monthly or 100 mg once daily. The frequency of therapy depends on the frequency of attacks. If the vulvovaginal candidiasis is more than 1 per month, weekly. And if it is monthly dose, twice monthly doses are usually adequate. Day 8 and day 18 of cycle for the hormonal peak. What are the side effects of oral azoles? Gastrointestinal headache actions with other drugs like astemizole, calcium channel antagonist, hypoglycemia, rifampicin. Coming to severe vulvovaginal candidiasis. Severe vulvovaginitis or vulvovaginal candidiasis, that is extensive vulval edema, formation with lower clinical with short topical oral therapy. So it should be treated either 7 to 14 days of topical azole or 150 mg of fluconazole in 3 sequential doses, 7 to after initial dose. Now coming becomes a longer duration therapy with a non-fluconazole azole, that is nystatin paste series, once a week or twice nightly for 14 days. Second line, if then vaginally 600 mg gelatin capsule once per day for 14 days is also effective. The cure rate is 70%. Treatment with amphotericin B suppositories 50 mg nightly for 14 days shown to be successful in 70% with non-candida albicans VVC due to Candida glabrata. The final resort is topical 17% flucysteine alone or in combination with 3 cream daily 14 days but it's expensive because of the high cost of cystosin. If non-albicans VVC continues to recur, a regimen of 1 lakh unit of nystatin delivered vaginally. Intravaginal painting with gentian violet and oral progesterone be used, but it has got there is little information about it. Another drug which is voriconazole, 100 mg twice on first day and then 200 mg twice for next 13 days. Comparatively, lower dose and shorter duration of treatment with azoles effectively cure the persistent vaginal candidiasis and improve the quality of life. Another regimen which can be given for the refractory chronic vaginal fungal infection by Candida glabrata, posca, which is a vaccination, or 400 mg with food. Local treatment you can give in morning, evening and at night. Morning and evening you apply cyclopyroxalamine cream, that is in 35 mg, introduced deep into the vagina, apply to the labia under force lateral perineum to anus. It's done in evening, and additionally at night nystatin ovula is inserted at depth once daily. Compromised host, correction of prolonged 10 days. Coming to VVC during pregnancy. VVC is more common during pregnancy. There is no evidence that VVC is harmful to the baby. Drugs are than nystatin. 7 days. Treatment for more than 1 week or more than 7 days confer no extra benefit. 4 days course will cure half of the infection, and 7 days course will cure almost 90% of the patient. That any one is any time more effective than another. Oral antifungal is not known to be effective or safe in pregnancy. Coming to recurrent vulvovaginal candidiasis, the recurrent candidiasis defines more of an year. It's a small less than. The pathogenesis is poorly understood. With RBV predisposing condition. Candida glabrata and other non-albicans Candida species are observed in 10 to 20% of the women with recurrent vulvovaginal. The conventional antimycotic therapy are against these non-albican species as against Candida albicans. RVVC, the reappearance of Candida in the vagina of the patient may either detected residual population of Candida or reinfection. The vagina is reinoculated from some extravaginal source. Although iron deficiency anemia has been suggested as a cause of recurrent VVC, there is no evidence to support this. Diagnosed. Is HIF immunology with RVVC. So, mechanism one can say there may be increased Candida virulence, and about host factors may be decreased local immunity IgE mediated hypertension, loss of lactobacilli, which has got a protective effect. Recurrent vulvovaginal candidiasis are treated with 7 to 14 days of topical therapy or 100 milligram, 150 or 200 every day for this. Oral fluconazole, so after initial 3 doses, give it weekly for 6 months is the first line maintenance regime. If this regimen is not feasible, then topical treatment used intermittently can also be considered. Recurrent vulvovaginitis is usually due to azole susceptible Candida albicans. Coming to comparison of antifungal agents, pyrrolering mainly used to treat VVC in clinical practice. Pyrrolering drugs such as imidazole and triazoles are related to inhibition of ergosterol synthesis in fungi and integrity fungal cell membrane and achieve the antifungal effect. The most common drugs represented by imidazole are clotrimazole, ketoconazole, miconazole, and the triazoles are represented by miconazole and itraconazole. And a high and strong antifungal associated liver toxicity is relatively small. Fluconazole appeared to be best drug for the treatment of VVC. Triazole or competing the ergosterol. It has shown a significant effect in the treatment of deep fungal infections, especially those caused by Candida albicans and Cryptococcus neoformans. Terbinafine, it is used in 500 mg per day for fluconazole 150 mg single dose are complete difference in the clinical or overall cure rate among these 3 antifungal agents. This is a susceptibility of Candida species, which is compared with all these species: Candida albicans, tropicalis, principalis, glabrata, cruzi, and various drugs which are used for the sensitivities: fluconazole, itraconazole, voriconazole, fluconazole B. This is the Oxford University Press report. The CDC-recommended treatment regimes for uncomplicated VVC, to summarize, prescribed and prescribed oral agents are there. You can have butoconazole 2% cream, 5 gram intravaginally for 3 days, or clotrimazole 1% cream, 5 gram intravaginal for 7 to 14 days. If you increase concentration, clotrimazole 2%, 5 gram intravaginally, then it can be 3 days course. Miconazole 2 gram 2% intravaginally, or miconazole 4% cream for 3 days. Miconazole 100 mg vaginal suppository can be used as one suppository for 7 days, or 200 mg Miconazole 1200 mg vaginal suppository, one suppository for 1 day can be used. Thiaconazole 6.5% ointment, 5 gram intravaginally, can be applied as a single application. Butoconazole 2% cream, 5 gram single dose bioadhesive product, intravaginally for 1 day. In 1 lakh unit vaginal tablet, 1 tablet for 14 days. Or turconazole 0.4% cream, 5 gram intravaginally for 7 days, or 0.5 gram. Turconazole 80 mg vaginal is 3 days. Conazole 150 milligram oral tablet, 1 tablet as a single dose. So this is what is recommended by CDC. Other preventive measures apart from the medical line of treatment: wipe the lesion from front, garment, washing, use of bubbly baths and perfume soaps. Patients should be counseled and educated about nature of the disease, transmission issues and risk reduction. Avoid douching, avoid unnecessary antibiotics, complete the course of treatment. So this completes the topic of VVC Vulvovaginal Candidiasis. Thank you.